we've got a sort of an interesting case from an access standpoint that I wanted to talk to you about today and kind of get you up to speed about what we did last week and some of the rationale about where we're going today. So this is an 82-year-old gentleman who was referred to me by one of the pulmonologists in town who is participating in pulmonary rehab due to rather moderate to severe COPD, but he's having difficulty walking because he claudicates in both legs at about 50 feet. He has hypertension, hyperlipidemia, prior tobacco use. About 10 years or so ago, he had a fem-fem bypass for a right chronic iliac occlusion. And that graft is readily palpable in the suprapubic region. His pedal pulses are relatively weakly monophasic Doppel, and his ABIs are 0.49 and 0.47 respectively. So I got a CT angiogram on him. This is the results right here. His right common iliac is chronically occluded. His fem-fem graft is patent. He has long bilateral SFA stenoses or occlusions. It was reported on his angiogram that he had bilateral popliteal 90% stenoses with two-vessel runoff to the feet. So I brought him in last week and accessed his fem-fem graft directly to fix his right leg. And I wanted to, if you can bring up the slide, the picture that I have. What I chose to do, part of the problem that he had is when we IVUSed his SFA was about 3.5 to 4 millimeters. And I think it was atretic from lack of flow and subsequently occluded. But part of the problem to me is when you re-intervene on these people is how do you keep a vessel that is small with atretic flow that's being stolen into the profunda, how do you keep that patent? And from flow dynamics, to me, the only way that I can think of is to make the vessel larger. And so what I did last time is I brought him in and I did a laser atherectomy and put a long kind of full metal jacket of 8 millimeter nitinol stents in a 4 to 5 millimeter artery. And I want to show you what happens to those stents in a week's time. So can you bring up the picture from last week? And this is what those stents look like. So what you're seeing on the left panel is the 8 millimeter stents that were post-dilated with the 5 millimeter balloon. And now this week, this is the same mag, exactly the same picture. Those stents are now 8 millimeters. And they're gonna preferentially steal flow from the profunda and keep that vessel open. And that's been my experience over time. So I'm gonna have a similar strategy on the left side. I just wanted to hear what you guys thought at that point, and then we'll kind of show you where we're at today.
Hey, Eric, is
there anybody that?
Hey, I had a similar case.
Yeah.
It was in the iliacs, and I think there is some truth to that. But I think you have to image and just have at least some sort of baseline before you do it. But it's an interesting case, and I've experienced the same thing, just at a higher level.
Eric, you using IVUS in your OBL?
Yeah. Yes, and I'm going to show you the IVUS images as well once we get going here. Yeah, we've done a full IVUS run, and it's the same anatomy on the left side. You know, and the problem to me is if you've got a large profunda that's 6, 7, 8 millimeters in diameter, and you've got a 3 millimeter SFA, I don't care what devices you put in there, it's gonna re-occlude shortly just because of flow steal. And so, to me, if you can stretch that artery open, at least get it patent, get some flow running down there, even if it does restenose down the road, I think we can come back at a later time and more of a definitive therapy and DCB and so forth. But let me show you where we're at.
Eric, it's John George. Just a quick question about your intervention last time. What was your runoff at the end of the case? Because I'm sure that plays into the patency of that right SFA as well, right?
Yeah, no, he has two-vessel runoff on both legs. The right leg is a little better. The left leg, it looks like it's occluded at his dorsalis pedis. I'll show you those pictures. But the runoff is pretty decent. His posterior tibular is occluded at the origin on both sides. No, that's a good question because I do think that does play a big factor in it. So let me show you some of the pictures of what we've done so far. This is our access. This is a micropuncture access. I always kind of like to show this picture because it's a little strange to watch a wire going through the bladder. It's a little disconcerting if you're not sure where it's going. Went ahead and put a 6 French sheath in. And then this is our initial picture just to confirm where we're at. And what I want you to notice is the size and the runoff of the SFA is now bigger than the profunda. And here's a runoff down the right leg. The flow pattern is faster in the SFA than it is in the profunda, and I think that's going to keep the artery open. He had a stenosis there that I put a superior in right across his knee. It was about 95%. Now he's got brisk flow all the way down into his foot. So I'm trying to accomplish a similar result on the other side. So that was our plan for today. So this is where we're at right now. We took a runoff picture. Again, he's got a very small stump of an SFA. His profunda's got disease in it in that mid-segment. Long SFA occlusion that's got severe calcium in the adductor canal, but for the most part, there's not a lot of calcium in the remainder of the entirety of the vessel. His anterior tibial and perineal go to the ankle. It appears that his dorsalis pedis is probably occluded at the ankle joint level. I was trying to get some pictures down there, but he kept moving his foot, and so I didn't get a great picture of his foot. But this is runoff beforehand, and you really see there's not much coming down there at all. And that's not surprising if you look at his anatomy, 0.4 ABI. So what we did was this is a road map. I've got a support catheter down in the profunda with a glide wire. I pulled the support catheter back into the graft and then kind of fished around and found the ostium of that SFA that was a little funny takeoff. It was a little hard to kind of hook into there, but eventually the wire hooked down there. I also want to mention whenever I do these cases with graft access, I always give these patients 2 grams of ANSEF. That's not my routine on my normal cases, but I always think it's a concern to get these grafts infected, and so I've always given ANSEF, and knock on wood to date, I've never had any issues with those getting affected. Eventually that wire is going to drop down into the SFA, there we go, and followed that down. Now what I did here is I just gently pushed the quick cross catheter and the glide wire. I kind of hooked that little stump right there and barely had the glide wire at the end of the catheter, and this went down pretty smoothly without a whole lot of resistance, just gently pushing on the catheter all by itself and kind of tracked down all the way down into the adductor canal. Once I got down there, I started running into the calcium. It started tracking a little bit subintimally, and you'll see that on the IVUS, but for the most part, that's all true lumen. And then I kind of worked it around and eventually got the wire going all the way through there. And this is just a runoff shot from below. You can see that his tibial arteries are really not too bad. Anterior tibial and perineal track all the way down to the foot. And there he's moving his foot. That's kind of a shot where it looks like his dorsalis pedis is occluded. And then here is what we did then is we switched out for a NAV6. We put a distal embolic protection device in. There's our filter. And then we've subsequently IVUSed it. And I don't know if we can play the IVUS run now, but if we can play that IVUS run. And then that's where we're at right now. So this is a pullback all the way from the popliteal coming back. You can see the calcium in the adductor canal. There's one little short segment where it looks like the wire is fairly subintimal for maybe a couple centimeters, but otherwise it's pretty true lumen, I think. But when you look at the size of this SFA, to me that's just vastly undersized for the body size of the patient. And I'm concerned that just simply a simple atherectomy and any kind of balloon is not going to keep that artery open. Can you go to the measured images of the proximal SFA? So this is the proximal SFA that was slightly open, and then go to the next image. That's kind of mid SFA. I mean, you're talking about a 3.5 to 4 millimeter artery. So any thoughts at that point?
Eric, this is actually a really fascinating point that you're making here. I mean, with if you go purely by the IVUS, you would potentially grossly undersize your stent. Because I'm assuming you're suggesting that the vessel itself has become atretic over time because of lack of blood flow.
Exactly, exactly. And so if we simply size this to our IVUS and use a 4 millimeter balloon and leave it alone, I think that we're going to be, it's going to be an early failure because the blood's going to steal down the profunda. So what we're going to do right now, if nobody objects, is we've got a 2.3 turbo power laser here that we're going to go, if you can hit ready. And we're going to go ahead and run this all the way down there, get a lumen, and then the plan is to use a DCB in the distal segment, which I think is probably the place with the calcium of the highest restenosis. And then we're going to put a full metal jacket with 8 millimeter stents in here and underdilate them with the 5.5 millimeter balloon and let them open up over the next week or so like the right leg did. So you may not be able to hear me with the laser, so if you have any comments or questions, I'd be interested to hear what the panel has to say about this.
Hey, Eric, Larry Diaz here. So how do you decide to go with an 8 millimeter stent versus a 6 or a 7? You just wanted to make it bigger than the profunda, was that it?
Yeah, 8 millimeters kind of been my go-to stent for the SFA. I think that a lot of these vessels are much bigger than you think they are. And if you really believe it probably was a 6 millimeter vessel one time, then oversizing it by 2 millimeters is 8. That's where I get my math from. I think that we were born with 6 millimeter SFAs, particularly in average sized men. And I think this became atretic over time because of flow. Okay.
Have you had any issues with perforations because of the sizing?
No, and that's another key point because when you gently stretch the artery, it's no different than doing a slow balloon inflation. If you acutely made it 8, it would rupture immediately. But if you put a 5 millimeter balloon in there and let the stent gradually expand, it's going to be fine. You're going to stretch it. It's not going to perforate. Now, what we're doing here is just kind of go ahead.
Yeah, so Eric, just you may have been getting ready to say this, but just from a technique standpoint, so you've got your tech hitting both directions simultaneously, right? I see the catheter spinning around. You're not going one direction.
Yes. Exactly. Yeah, so with the turbo power, what we do is we hold down both buttons at the same time, and it rotates 180 degrees one way and 180 degrees the other way. And I'm just kind of going slow down through here and making a pass to really kind of debulk it as much as I can. But the goal here is not to make this a 5 or 6 millimeter vessel at this point. Okay, off.
So,
all right, and we're gonna laser going backwards too. Yeah. Yeah, I'm listening.
Eric, this is Lopez. So you're going to stent and then hit it ahead of the stent with a drug-coated balloon. Any thoughts on just using the drug-eluting stent?
Yeah, you could do that. I think that'd be a good option. If I had a drug-eluting stent, I would probably use one.
Size may be a problem.
I'm trying, yeah. That's the other thing, is the alluvia doesn't get to be that big. Back on a second. So what I'm doing right now is I'm just kind of sitting in this calcium more to pulverize it and try and microfracture it than anything. There's really not much probably debulking that's going on, but the shock wave of the laser is going to fracture this calcium. This technique that I'm talking about, where you grossly oversize these stents, really only works when you have not a lot of calcium. If there's a huge calcium burden, go ahead and back this off. If there's a huge calcium burden, this is not going to work. The stents are not going to expand. But really the only area of calcium is this adductor canal area. And so I tried to crack that open with the laser, and now we're going to put a DCB in here and let that sit for a few seconds and see how that works. And then we're going to go ahead and stent this.
Okay, Eric, another
let me have
technical
that,
question just for the
Yep.
audience. Do you have a set time frame that you know, because this was a long run, right? So do you break it up? Do you
Yeah.
do 30 seconds? What's your approach to super long laser runs?
Yeah, that's a great question. You know, if you look at some of the science behind it, there is probably some micro vapor bubbles that accumulate that probably cause some micro slow flow that's transient. Some people break it up and in shorter runs and let that dissipate. I've never been too worried about it. I think that eventually over time it kind of goes away. This balloon is going down pretty easily, but it's getting kind of stuck right there. And that's one of the things I was worried about. That's an 035 balloon, but I think that's probably going to be pretty good, because I think that's probably the area where we're going to have the most likelihood of restenosis. Let's go up there for a couple minutes.
Hey, Eric, Osama here. How you doing?
Yeah.
Really quick.
Good, how are you?
Good, good. What is the percentage that you use distal embolic protection, and why did you choose it in this case? Is it just the calcium, the length, what exactly? Or is there anything on IVUS that made you to think about using it?
You're gonna have to stick around for my Friday lecture, and I'll tell you all about it. No, but seriously, I think there are some predictors. If you really look at, let's go up to 6. If you really look at what embolizes and what doesn't, virtually every single lesion, every single thing you do to an artery has a potential for embolization. So if you really believe that you want to protect everything, it's probably the best idea to use a filter on 100% of the time. Now, does that happen? Not in real life. So I think the ones that are the chronic occlusions, the ones that have some thrombus, the ones that are highly calcified, if there's clinical issues with, you know, you have single vessel runoff or CLI type patient, then I think those are legitimate reasons as well. But for the most part, you know, you're going to have embolization almost every time. And so it's really a question of whether you want to use a filter on every time or not.
Eric,
I've always said it's like breaking a saltine cracker over a table and being surprised there's crumbs on the table when you're done.
I think that's very
So,
true. Eric,
yeah.
Lou Lopez again. Prior to doing your live case, we were having a little discussion up here, and I'm curious about your opinion. Several of the people here on the panel, their institutions have asked them to eliminate their use of drug-coated balloons because they feel it's a medical legal issue. Myself, I still am a strong proponent of drug-eluting technology, and I think that the data out there is not certain one way or the other, and the benefit to the patients are enormous, and so I use them. I don't know what your opinion is, but I'd be curious.
I think any hospital that's taking them off the shelf is bullshit, and it is absolutely wrong.
I think a lot of hospitals do that to try and save money.
Well, they may be trying to do that, but it's clearly not in the patient's best interest. So, come on down.
Well, I would echo that. I appreciate your saying it.
I agree with you,
Yeah,
Eric.
no, I think that the data on that is very sound. I think that the Katsanos paper is a bad analysis of bad data. And when you put crap in, you get crap out. And that's exactly what happened. When you look at there's a 40% crossover in that trial. 40% of the patients that were in the PTA arm had a DCB. And that was analyzed on an intention to treat, not on a per treatment basis. Plus, many of those PTA patients were not followed beyond 1 year because they were felt to be a, quote, safe procedure. So again, it gets back to my point. If you truly believe that the technology works, then you should be using it. And I don't think that there's an issue. There's nothing, in my opinion, that can make someone die at 5 years by getting a few crystals of paclitaxel in their toe. That absolutely makes no sense whatsoever. And unless somebody can explain how that happens, I just don't believe it.
One of the things I would put forth is
So we just,
I can remember very well the days when we didn't have drug-coated balloons, and we had patients that were coming in every 3 or 6 months with restenosis, and I have to face these patients and talk to them and explain why they need to have another procedure. And the advent of drug-coated balloons has been a godsend in terms of their durability of treatment and their outcomes. And so that's my opinion.
yeah, there's no question in my mind. So we dilated that adductor canal segment with the 5x120 Stellarex balloon. Right now we've got a 5x200 Minerva balloon from Brosmed. This is distributed by US Endovascular. This is a nice balloon, good low profile, and I think it works great in an OBL setting as well. We're just going to dilate this whole thing, kind of low pressure. So what I'm doing right now is just kind of going up to 4 atmospheres, enough to kind of open the balloon up. Okay, going up there.
Eric,
And then we're going to put some stents in, and we'll be done.
Quick
So I have
question.
another
Yeah.
question regarding your technique of putting in an oversized stent, initially under-dilating it, and then allowing it to expand slowly over
Yep.
time. Do you think that
Yeah.
strategy reduces the chances of perforation because it very slowly stretches out the artery over time?
Yeah, there's no question in my mind. I've never had a perforation doing this at all, never. And so first of all, the SFA is too muscular of an artery. Unless you're completely subintimal out in the adventitial space, you're never going to perforate the artery from that. Maybe from let me have a stent. Maybe if you're way out in the subadventitial space, but not at all in an SFA. Now, if you grossly oversize a bypass graft, like if you have a FemPop bypass graft, the veins themselves, I've had one of those tear late, and came in about a week late with the hematoma in his leg, and it was because of that. So the veins are a little, have a weaker integrity, if you will, so I don't typically overstretch veins too much. Kind of learned the hard way with that, but I've never had a vein or an SFA perforate at a late time because of that. And
Eric,
again, I think it prevents some of the barotrauma.
One of the thoughts
Yeah.
here, Eric, is that the question whether the artery is being overstretched or whether it's growth of the artery because these are hibernating vessels in a CTO. And there's some data in the coronaries, and this is great display with your imaging, that these arteries are small to begin with only because they're occluded, and that as you have increased flow that they continue to grow. And I wonder if you've done imaging post balloon dilatation or after you've improved flow to that vessel before you stent it to see what the size is or if there's actually increasing growth from your initial IVUS imaging.
Yeah, no, I think that argument of chronic overstretch is potentially valid, but I think that eventually what happens is the stent probably has a millimeter or so of restenosis, and the artery will find its natural position again. But I think in the short term, if you don't keep this open in the next week or two, it's going to just clot off right away, and that's been my experience. And I don't think you can get that with any other device or any other, just a plain balloon. I mean, DCBs are meant to prevent late restenosis, not keep vessels open in the short term. That's what stents were designed for. Now, you can make an argument that you don't need this stent in there in a month, and you may not, so maybe a bioabsorbable stent would be a better choice. But right now, we don't have those either.
Eric, what kind of stents are you putting
But I
in there?
think the ultimate, yeah. What's that?
What kind of stents are you putting in there?
These are, this is an 8 by 150 smart stent. And what you'll see is it looks like it's about 4 millimeters or so. And if you remember the picture I showed you, the right leg at the beginning of this transmit, it's going to be 8 millimeters in a week. So now what we're going to do is we're going to take a picture and figure out what the stent length is for the last one here. It looks like it's probably going to be about an 80 or 100 or so, but let's see here. How are we doing on time, guys?
We're just a tiny bit over.
Well, if you need to go, I can take a quick picture right now, but let's just take a quick picture right here and I'll show you what we've got. Ready? So I think that's going to look great. We're going to tack that proximal segment up. Let me do this here. What I'm going to do is I'm going to measure this and see if we can get kind of more of an accurate, more accurate length on this to the top and see what we need. So we want to go right to there. So we're going to measure from right about the ostium down to that stent. We'll say right there. So that's 9 centimeters. Let me have a 10 centimeter stent. Do we have an 8 by 10? 8 by 100, yeah. So, all right, they're telling me 2 minutes. So what I'm going to do is I'm going to come over here. We're going to get this last stent in. We'll try and get you a picture here real quick. So what I'm going to do for this is I'm going to mag this up. We're going to make a little road map. And we'll see if we can just hit that right on the edge there. All right. So,
Hey, so Eric, before we take off,
So if you
what's your
guys have-
strategy on getting out? We know how you got into the graft. What are you going to do in terms of, are you just going to hold pressure? Are you going to use a device? How are you going to get out of that graft?
no, that's a great question. I'm glad you brought that up. This is an 8 millimeter graft, and they do phenomenally well with an angioseal. And so that's been my strategy. I don't think Perclose is working them. Because of the location and kind of the suprapubic region, it's really a difficult area to hold pressure on because there's nothing behind, so to speak, nothing behind the graft to push on, so you don't get a lot of pushback. But the angioseal does remarkably well because of the size of it. There's no disease or anything where the foot plate gets caught. I've never had an angioseal fail or anything like that. So we're going to put that right at the ostium of that SFA right there. And then we can get you a quick picture, and then we'll dilate this some more at the end. And if you guys need to go, that would be fine. But what we're going to do here is take that 5.5 balloon that we had in there and dilate that back with the 5.5 balloon, and then we should be done. Yeah. All right. If you guys are going to cut out, I want to thank everybody at NCVH.
Eric, excellent case, and thank you for all your
Yeah,
discussion.
track.
We appreciate it, Eric.
Tracking
Thanks
device.
so much.
Sure thing.